All right, we're going to get grand round started. So first, to remind the residents and the faculty that we have our group photo. Grand round, right in front of the symbol down there immediately after the grand rounds. So, grand rounds today, Dr. Walyat. Nitin Walyat is the director of our Acute, and he's going to talk about Neonatal, Arterial, and Venous Thrombosis.
Thank you. So I'm required to say this. I have no relationships with industry to disclose anything relevant to the content of this CME activity. So we will review the incidence of thromboembolism in neonates. We will discuss the pathophysiology of neonatal hemostasis, and then we will review some treatment guidelines. Among children, newborns, they are very vulnerable to thromboembolic events. And among neonates, babies who are more sick, they are at more risk of developing symptomatic thromboembolic events. We don't have a lot of good studies or trials in neonates. So whatever evidence we have, or in fact most of the evidence we have, is from adults or older children. These are some of the incidents I got. One is from Canadian registry. It says symptomatic thromboembolism is about 2.4 per 100,000 NICU admissions. One is in German prospective registry, and it was 5.1 per 100,000 NICU admissions. 80% of the venous thromboembolism is related to central venous lines, and studies have shown the incidence is higher in femoral lines as compared to internal jugular or SVC lines. We place a lot of UVCs and UAC catheters in our babies. One study showed the autopsy finding related to UVC related venous thromboembolism was between 20 to 40% of infants who died and had UVC in place. That's a significantly high number. Clinical studies, mostly ultrasound, shows the incidence is between 13 to 30%. I'm going to mention few slides about portal vein thrombosis. Silent portal vein thrombosis in one of the studies was seen in 43% of the neonates. And we know the most common cause of portal vein thrombosis in newborns is UVC placement. This is one study which was done in Toronto Sick Children Hospital, and they found 73% of the infants had UVC related portal vein thrombosis, and 46% of them actually had a UVC in correct place. But the grade 3 portal vein thrombosis was more related to UVC being placed either in the liver or a low-lying UVC. This is one from one of our patients, and you can see the portal vein thrombosis. The significance of portal vein thrombosis is most of the time it resolves, but if unresolved, it can cause portal hypertension, which can be a serious disease in older children and adults. And Maribel is going to do a QI project in our NICU, and we are going to look at portal vein thrombosis in relation to UVC placement. Coming to arterial thrombosis, again, clinical signs and symptoms, what we see is less than UVC, but still is very significant, 3 to 5%. And ultrasound-based studies shows UVC or UAC related arterial thrombosis to be between 14 to 35%. It is most commonly secondary to UAC or peripheral arterial line placement. Any thrombosis in the artery has a lot of risk. The big one is you can have any limb or organ threatening injury. You can lose fingers, you can have a severe injury to the limbs. So we have to take this very seriously. The other problem we see in our NICU is the loss of patency in the arterial lines. As you see, the incidence comes down significantly in the presence of unfractionated heparin. Any arterial line which we place, you have to put a continuous heparin infusion, because if that gets blocked, it can cause thrombosis and it can also affect your organ or the limb. We are going to spend a few minutes on the physiology. The neonatal hemostasis or hemostasis in older children, adults, basically has to be discussed under 3 headings: coagulation, anticoagulation, and fibrinolytic system. This is a basic mechanism. Any vessel injury, you have vasoconstriction, the blood flow is reduced, and the platelets adhere to von Willebrand factor, and then they aggregate to form a hemostatic plaque. Then there is intrinsic pathway, extrinsic pathway, and I'm going to talk about these pathways in detail in next slides. We all know all these coagulation factors. I think every one of us know all these. So this is a very busy slide. On this side is your intrinsic system. This is your intrinsic system, and it includes the anticoagulation and then fibrinolytic system. We will break this slide into individual components. First is the coagulation. Again, this is the intrinsic pathway, and this is your extrinsic pathway. The end result of all these pathways or the cascade is the activation of prothrombin to thrombin, which converts fibrinogen into fibrin, and then they are cross-linked with the help of factor 13 and forms a clot. This is the anticoagulation. The important anticoagulant factors in the blood are protein C, protein S, tissue factor, pathway inhibitor, antithrombin, and all these anticoagulants, you can see in the dotted arrows, they inhibit all these factors. We use heparin, and the way it acts is it potentiates the action of antithrombin and ultimately inhibits this coagulation cascade. The third component, which is very important in neonates, is the fibrinolytic system. So the tissue plasminogen activator converts plasminogen into plasmin, which breaks the fibrin into fibrin degradation products. The reason it's important in neonates is neonates have very decreased or reduced plasminogen. Secondly, you see this, this is plasminogen activator inhibitor. It inhibits this fibrinolytic system. Newborns have very high levels of plasminogen activator inhibitor. So what it causes is newborns are prone to thrombosis. They have reduced antithrombin 3 heparin cofactor protein C levels, which are the major anticoagulants. They have impaired fibrinolytic system, so they cannot break the clot. So we should remember newborns are prone to thrombosis. Plus, if they have any underlying disease, they are septic or they have underlying thrombophilia, they have any cyanotic heart disease which will cause polycythemia and will increase the blood viscosity. Plus, they are born with high hematocrit. Okay, so all these factors predisposes a newborn to thrombosis. So when I say the hemostatic system is immature, it means they have reduced anticoagulants and they have impaired fibrinolytic system. Newborns have small vessel diameter, they can have an underlying disease, and the big one is we place catheters in our newborn babies. So that predisposes them to thrombosis. Plus they have very small blood volume, and which makes all this blood workup very challenging. There are different types of thrombosis. Again, the major ones are catheter-related thrombosis. That's what I'm going to discuss today, the arterial and venous. Non-catheter related are renal vein thrombosis, stroke, congenital thrombophilia, or pulmonary embolism. But we will focus mainly on catheter related thrombosis. The diagnosis, clinical, is the big one. We rely a lot of in the newborns on our clinical parameters. There are some lab testing which again is different in newborns, and role of imaging. I wanted to mention few things about clotting factor times. They are different in newborns. Prothrombin time of 11 to 12 could be normal in older children and adults. But in newborns, they usually have higher values. These values in preterm, basically what the reference values we have is from cord blood. But you can see even like prothrombin time of 18.2 is within normal levels. So doesn't mean that if you have a elevated prothrombin time of 15 or 16, that baby is in DIC. It could be normal for a newborn, especially preterms. I put one slide. These are the reference values on day 1 of life. And you can see the prothrombin time in less than 28 weeks, even 21 could be normal. You have to rely more on your clinical picture, but prothrombin time can be normal. And you look at this fibrinogen levels. This 90 in older children or adult means that patient is in DIC. But in newborns, it can be normal on the higher spectrum, but the values are different. The imaging studies, the gold standard is the venogram, but it is very difficult to do a contrast study in a newborn. Contrast can be nephrotoxic, plus it could be difficult to do in a newborn. Most commonly we do ultrasound and echocardiogram. Ultrasound compared to venogram has poor sensitivity and specificity. Plus, this is very important. It depends on who is reading the ultrasound. The other imaging studies, if you're concerned about neonatal stroke, we should do MRI, but we should always include MR, angiogram, and venogram to look at the cerebral blood vessels. Doppler studies for renal vein thrombosis. I put this ventilation perfusion scan and angiography here, but we very rarely use these studies in our newborns. These are some of the pictures. These are from our patients here. This is thrombosis in a femoral artery. Baby had a femoral venous line, and the artery was nicked and developed thrombosis in the femoral artery. This is another slide of thrombosis in the femoral artery. This is a slide of stenosis in the renal artery. And these are from the real patients. The management, we do prophylaxis. We will talk what prophylaxis means, the acute management, and then follow-up. Again, the drug metabolism is also significantly different in newborns. If we are going to use heparin in newborns, they need higher dose because they have increased clearance of heparin, they have increased volume of distribution because they have more extracellular fluid, and there is accelerated drug metabolism too. And you can see the half-life is very short, 25 minutes, as compared to 70 minutes in adults and older children. The unfractionated heparin has a higher molecular weight. The way it acts is it acts via antithrombin and mediated inhibition of thrombin and factor 10A. Thrombin is factor 2. It has a very short half-life, and one of the big disadvantages of unfractionated heparin is it can only be given via IV route. Okay, if you have to send a baby home, it's difficult. You can't send the baby home on IV heparin. So we use low molecular weight heparin. This is the drug of choice. It has a longer half-life. It can be given subcutaneous. It has less tendency to cause bleeding and heparin-induced thrombocytopenia, and the response is more predictable. So this is, if we have to use anticoagulation, this is the drug of choice. The third drug is tissue plasminogen activator. This is a thrombolytic. It is a highly potent drug, and we will discuss that there are only few indications to use a thrombolytic drug. This is not the first drug of choice because of the bleeding potential. So coming to prevention, if we are going to place a UAC, there are two positions. One is high umbilical position, which is between T6 and T9, and low-lying position, which is L3, L4. But studies have shown the UAC-related thrombosis can be reduced by placing a UAC catheter between T6 and T9. As I mentioned previously, if we are going to place any central line, there has to be a continuous infusion of unfractionated heparin, 0.5 to 1 unit per hour. There's Cochrane meta-analysis in 2012, and it showed the PIC catheters, they had a low occlusion rate if we had a continuous unfractionated heparin infusion. Again, continuous infusion is better than intermittent flushes. And the studies have shown there is no any increased risk of intracranial hemorrhage with heparin prophylaxis. When we do the TPN orders, the residents will know this, you always check 1 unit per ml. Okay, so that will give you about 5 to 6 units per kilo per hour. It looks like a high dose, but that is okay, and it is not going to cause any bleeding, intracranial, retrocranial. So any central catheter you place, it has to be, we have to infuse continuous heparin. Incidence of heparin induced is low in neonates. I've searched the literature and I could not even find any case report on it. It's mentioned, but it's not seen. In adults, they use heparin-coated catheters, but regarding newborns, there's no studies to show this. But in adults, they use heparin-coated catheters. Again, just to make things very clear, any central line, heparin has to be ordered. Don't order any flushes, order a continuous infusion. Again, this is a very important slide. What is the duration of the catheter? The first point is it should be minimal. If you don't need a catheter, take it out. UAC, if you have a sick neonate, you place a UAC, but if the baby is stable, it should be taken out. It should not be there for more than 7 days. For UVC, CDC recommends mean duration of 7 days, but certainly no longer than 14 days. Because longer duration of this catheter will increase the risk of thrombosis and infection. If you don't need a catheter, pull it out. The acute management of thromboembolism. Supportive care is giving fluids, maintaining the vitals. The big one is anticoagulation. And the drug of choice, as I mentioned earlier, is low molecular weight heparin. Thrombolytics, rarely used in newborns as a first line of drug. And again, the rare interventions are thrombectomy and interventional catheter directed lysis. Again, very rarely used in newborns. The benefits to risk ratio. The biggest risk with all this anticoagulation, thrombolytic is the bleeding. But if there is a thrombosis, it needs to be treated. So the benefits, of course, are recanalization of the vessel, and if there is any critical injury to the limb or any organ, it needs to be treated. The other thing we're going to discuss later is when to treat. There could be babies who have a clot, but they are asymptomatic. So the first thing that comes to our mind is, okay, if it is asymptomatic, we will just follow this clot or thrombosis. But if there is more than 50% obstruction of the vessel involved, it needs to be treated. If it involves any critical vessel like IVC, superior vena cava, right atrium, or any significant cerebral blood vessel, it needs to be treated. Any arterial clot, you have to treat it. Arterial clot, doesn't matter how big it is or what vessel it is, it has to be treated. The absolute contraindication is if the baby had a significant major surgery in last 10 days or any major bleeding. Major bleeding means significant intracranial bleed or significant retroperitoneal bleed. There are certain relative contraindications: severe asphyxia, low platelets, low fibrinogen, And of course, if you are planning to treat this baby, try to avoid any invasive procedures. The complications, the big one, or what we are concerned about, is the bleeding. The studies have mentioned it's somewhere between 2 to 5%, but if the baby is sick, it could be higher. Again, heparin-induced thrombocytopenia, it's mentioned between 0 to 40%, but again, there are no ways of confirming this in a newborn, and there are not many studies or case reports on this. Osteoporosis seen in older children and adults, but not in neonates. So most of the guidelines what we have regarding the anticoagulation, thrombolytic, they come from American College of Chest Physicians. That's where you will find the most available guidelines. The last one I had was from 2012. The low molecular weight, for the drug of choice, this is the recommended dose. You should always consult a pediatric hematologist, and this is the recommended dose. If the creatinine clearance is decreased, the dose needs to be reduced as well. This is the prophylactic dose. And we have to obtain anti-10A levels 4 hours after the second dose. And this is a table, you can find it in all the standard textbooks. The anti-10A is maintained between 0.5 to 1. Again, before doing any of these stuff, we should always talk to a pediatric hematologist. I mentioned a lot of good things about low molecular weight heparin. One drawback is if there is toxicity or overdose of low molecular weight heparin, we have protamine, which will reverse the toxicity of heparin. But in low molecular weight, it only reverses up to 60%. Okay, so that's one drawback of low molecular weight heparin against unfractionated heparin. If you have any overdose of unfractionated heparin, you can completely neutralize it with protamine. But with this, only 60%. And this is the dose, how much protamine has to be used. We'll talk about some studies regarding the use of all these drugs. This is one study in which low molecular weight heparin was used. It's a prospective study, and 62 newborns were there in this study. 69% of the infants in this study had catheter-associated thrombosis, and there was complete or partial resolution in 50% of the newborns. Also, preterms required higher dose of low molecular weight heparin as compared to term, and they also required longer duration. So it is difficult to treat newborns, especially preterms, for their thrombosis. In this study, 4 infants had major bleeding. 2 of them had the bleeding at the low molecular weight side. 1 patient had a severe malformation of the heart and had a small intracellular bleed. 1 infant had a superior cerebral thrombosis, and he had a major cardiac surgery which caused the bleeding. So in this study, 4 patients had bleeding, but none of the bleeding episode resulted in death or any sequelae. So low molecular weight heparin is an acceptable treatment of thrombosis in neonates. And again, preterms are difficult to treat, and they require longer duration as well. From this study, it was associated with relatively low risk of bleeding. This is another case series in which 3 neonates were diagnosed with aortic arch thrombosis, and that caused multiple ischemic infarcts in the brain. None of these 3 neonates had hemorrhagic infarcts. So they were started on low molecular weight heparin, and the anti-10A levels was titrated between 0.5 and 1. So this baby had a complete resolution, this baby second one had a partial resolution, and the third one had a complete resolution. I'm just going to mention very briefly about unfractionated heparin. It used to be used in past, but last 10-12 years, this is no longer the drug of choice. And again, the big drawback with this drug is you have to give a loading dose. And we all get scared if you have to use this much heparin in a neonate. You're scared, you're going to bleed. We've seen our ECMO patients, they routinely do this. It is safe, it's recommended. The way heparin acts, you have to give this. But again, there is more risk of bleeding, especially in a sick neonate. And then you have to do continuous monitoring because it has a shorter half-life in neonates. And again, the only route you can use is IV. It has to be given continuous infusion at this rate. Again, you have to maintain the activated partial thromboplastin time in this range. If there is overdose or toxicity of heparin, you use protamine. With unfractionated heparin, it can 100% neutralize the toxicity. Thrombolytics. There are only certain indications when you will use thrombolytic in neonates. If you had a failure of anticoagulation, you use low molecular weight, it didn't work, then you use TPA. If the massive thromboembolism had caused very severe or critical limb or organ compromise, you have a massive clot in one of your femoral arteries and you think you will lose the limb, so then you use TPA as the first line of drug. Other indication is bilateral renal vein thrombosis causing renal failure. And the last indication is in the thrombus in the right atrium but compromising the cardiac contractility. There is a thrombus and baby is in heart failure. That's when you will use TPA as the first line of drug. These are some of the contraindications: major bleeding, stroke, or severe asphyxia. Again, in neonates, we don't have any good studies. There are some case reports, but we don't have well-designed trials. All these doses come from adults and older children. This is the standard dose, 0.1 to 0.7 milligrams per kilo per hour. And there are studies in which they have used low dose successfully. And I'll mention those case reports later on. Again, if you remember, for TPA to act, it needs plasminogen so that it can be converted to plasmin. Babies have very low plasminogen, so you have to give FFP for TPA to work. And if you're going to use TPA, you have to use unfractionated heparin with it. Very frequent monitoring, because there is always a risk of bleeding. So you have to monitor these babies very carefully. The complete lysis is defined as 95% of the clot resolution. Partial lysis is between 50 to 95%. If you develop any bleed, significant bleed, intracranial or peritoneal, stop this drug. Again, you have to do the ultrasound at least once a day. You have to check all these fibrinogen platelets. If there is any risk of bleeding, stop this drug. So this was one study in which there were 14 neonates. They were treated with the same protocol. They had a catheter-related thrombus and they were treated with the same TPA protocol. Initial bolus of this 0.7 milligrams per kilo, and then continuous infusion along with heparin, which was used 4 to 10 micrograms per kilo per hour. And this is a description of these the babies. You know, they had a significant clot, right atrium, right atrium, right atrium, and the outcome. This baby had a complete lysis, complete lysis, complete lysis. One baby failed. Again, 3 babies had a complete lysis, and this baby only had a partial lysis. Again, all these babies had a complete lysis, but this baby had a local bleeding. So the complete clot resolution was seen in 11 cases. Partial lysis was seen in 2 patients. The duration of this TPA drug was about 3 days. There was a 1 treatment failure. Severe complications was not seen. So it did work, you know. Babies had significant clot, mostly in right atrium. TPA was used and it worked. There's another study in which low dose TPA was used. This is the standard dose we discussed in the previous study. In this study, they used a lower dose. They had 35 children and 9 were neonates. They defined the major bleeding and minor bleeding. Major bleeding, as we talked, it is intracranial or retroperitoneal bleeding, or any significant drop of hemoglobin, more than 2 grams per deciliter. And again, they monitored these clots very carefully, and they had a same definition: complete lysis, more than 95% resolution, partial was between 50 and 95. So again, these babies again had a significant clot. So this baby, they used a lower dose, 0.03. And again, in these 3, they were used, the TPA was used at a lower dose. So what the conclusion was, the TPA in low dose appears to be safe and effective in acute thrombosis if indicated. So the recommendation would be to start TPA at a lower dose. If it works, very good. If it doesn't work, you can titrate the dose and go up. But it is recommended to use TPA at a lower dose because TPA is a dangerous drug, can cause significant bleeding, and got to be careful in newborns. I'll discuss some guidelines very briefly. Again, all these guidelines are from American College of Chest Physicians. For venous thromboembolism, the first treatment, supportive care with radiological monitoring. If the baby is asymptomatic and the thrombosis is not in any critical site like SVC, right atrium, IVC, it's okay to watch and do a supportive treatment. If it is in a critical site or it occludes more than 50% of the blood vessel, we have to treat with anticoagulation. The recommended duration is 6 weeks to 3 months. One other thing which we see is, should we take the catheter out or not? If you see a thrombus and you are going to treat, theoretically it is suggested or it is recommended to leave this line for 3 to 5 days, because if you start treating, the clot breaks, it can lead to a paradoxical emboli. So with UVC, you can leave it for 3 to 5 days and then remove it. The thrombolytic therapy like TPA is only to be used if there is failure of anticoagulation or any critical compromise of organ or limb. It is not the first line of drug. For arterial thrombosis, the line has to come out. All the arterial clots have to be treated. And again, the same recommendation, if it is a critical involvement of any organ or limb or the anticoagulation fail, then you use the thrombolytic. Okay, so take the line out. The duration unfractionated is used initially 3 to 5 days, continuous infusion if used. Low molecular weight is 6 weeks to 3 months, and TPA again, when the thrombolysis is documented or achieved, you can use it and then stop. For renal vein thrombosis, there are some specific guidelines with renal vein thrombosis. If it is unilateral renal vein thrombosis and there is no renal impairment, we can do a supportive care and monitor the thrombosis with Dopplers. If this thrombosis is extending into the IVC, then you have to treat. If it is bilateral renal vein thrombosis with failure, that's an indication where you have to start with thrombolytic, tissue plasminogen activator with anticoagulation. And this is a case report in which there was a male neonate developed renal vein thrombosis and systemic TPA was started at day 18 of life along with unfractionated heparin. And 3 days later, Doppler showed adequate flow in the right kidney and IVC became patent. And then low molecular weight was given for 6 months. This baby had a GFR of 59 at 9 months. The other significant thrombosis we see in our babies is cerebral sinovenous thrombosis. Again, any baby which comes with a history of strokes, seizures, you have to do MRI with MRA and MRV. Because if you see a thrombus in a cerebral blood vessel, it needs to be treated. If you have a thrombus without any active bleeding, you start the treatment with anticoagulation. If there is any active bleed, you wait for a week, you repeat an MRI. If the clot is getting bigger, you have to treat, even in the presence of bleeding. There are two case reports. I put it in my slides. One of this is a female born at 38 weeks, had a significant thrombosis. Low molecular weight was started at 1.5 milligrams recommended dose, and the repeat head ultrasound 2 weeks later demonstrated clearance of this bleeding. In another case report, baby was born at 26 weeks. At 36th day of life, baby developed significant thrombosis in SVC. And again, low molecular weight heparin was started, and head ultrasound 4 weeks later showed clearance of this bleed. This baby also had a communicating hydrocephalus which resolved. So if there is any significant thrombosis in the cerebral blood vessels, it has to be treated. Again, you can have, this doesn't present that frequently in newborns, but maybe in older children, if they have arterial ischemic stroke, the recommendations are, if it is the first episode and there is no documented cardioembolic source, you can just watch and wait. Anticoagulation is not recommended. But if it is recurrent arterial ischemic stroke, then it has to be treated. And these babies, older children, the other recommended drug is aspirin. This is a study protocol. It's called Neonatal. It's being studied or being done in Netherlands. This is a big study, multi-center study, and involving 10 NICUs. What they are doing is they are actually following the guidelines from American chest physicians, and there are 4 recommended treatments. One is wait and watch, one is anticoagulation, one is surgery, and one is thrombolytic. But this study is in progress, so they are going to develop a study protocol. So the efficacy and safety of the anticoagulation. This is again very rare in newborns. We don't see it, but I found a couple of case reports. Catheter-directed thrombolysis. Theoretically, it should work. It can offer the local delivery of the drug at the thrombus. But again, in newborns, it will be difficult because of the size of the blood vessel and, more importantly, experience of treating newborns with this approach. This is one case report in, there was a 13-day-old baby had a thrombophilia workup, came back positive, and they treated with this. They placed a catheter in femoral vein and treated locally, and it worked. The last is the surgical. It is very rarely used in newborns, and it's not recommended. The reason it's not recommended is because there is a very high rate of reocclusion. Plus, you're putting this baby at risk for surgery, and it's going to come back. So it's not to be used in newborns. Other thing we see in our NICUs is you develop a spasm. You place a UAC, and then few hours later or next morning you will see the limb has turned pale or blue. If it is not a thrombus, it's only a spasm, you can try topical nitroglycerin. This is the recommended dose in newborns. You have to watch the blood pressure with it. Babies can have a drop in blood pressure. You can do this treatment, but it's only to be used for like few hours, 4 hours, 6 hours. If it doesn't work, pull the catheter out. There are some case reports, of documenting the efficacy of nitroglycerin. The babies, in this baby had the extremity was sinus, no pulse. They used nitroglycerin, and it worked. So again, the improvement, if it's going to work, it's going to work in an hour or so. Okay, but if it's not working, again, the catheter has to come out. So the critically ill neonates, they are at risk for thromboembolism. The catheters, we place catheters in our babies, and it increases the risk of thrombosis. Heparin is used as a prophylactic drug when we place all the catheters. One thing we got to see is evaluate the indication of catheter on daily basis. If the baby does not need a catheter, take it out. There is no need to leave the catheter for 24 hours, 48 hours. You can have thrombosis anytime, and also it can get infected. So if the baby does not need a central line, it has to come out. These are some of the references. The big one, again, all these guidelines are from American College of Chest Physicians. There are not many studies in neonates. Mostly they are case reports and very few trials. Our experience in treating thrombosis is limited. Again, if in doubt, you always consult the hematologist. That's it. Any questions?
Nicely done. First question.
Did they mention anything about using a lower dose of treatment if they have severe IV intravenous hemorrhage with a clot? Did they mention anything about reducing the dose?
For the low molecular weight heparin? No, the way you have to start this, and the anti-10A levels, they have to be maintained between 0.5 to 1. And sometimes we talk to the hematologist and they will say, try to keep the levels close to 0.5 instead of keeping it close to 1. But the dose is the same, you start at the same dose, but anti-10A levels, you can try to keep it close to 0.5.
Daniela?
On that neoclot study they're doing now, you said surgery is one of the possible treatment arms, and yet afterwards you talked about surgery being almost never done because of the high risk of reocclusion. Are they looking for the same number of babies in each group? Are they going to try to get the same number of babies in each group?
They have both preterm and term babies, but again, I don't know if they have the same number of babies in each limb. The surgery, the reason I started on this, when I started my fellowship in 2009, we had a baby with thrombosis in the femoral artery. And you won't believe it, the first treatment of what the baby went for thrombectomy. And a week later, baby developed another big thrombosis. And then from the recommendations from hematologists, baby was put on low molecular weight heparin. People have very limited experience with anticoagulants, and the first approach is to use a TPA or consult a vascular surgeon and go for thrombectomy. But again, whatever studies or data they have, there is a very, very high rate of reocclusion. So, but the studies have shown that low molecular weight heparin works. So if you have a drug which works, then use that, and if it fails, then use TPA. But surgery in newborns is not recommended. Again, it's very difficult, to just vessel size is so small.
That's why I was surprised to see that included as one of the limbs.
Yeah, one
of the study.
Donna, if I can address that, I probably have 4 slides of babies who have lost their limbs, lower extremity, upper extremity, and Jerudi will tell you time is of the essence there. So you have to work in conjunction with a good vascular surgeon. My personal thinking, as you said, it's extremely rare condition. So we don't have to ship the kid out to somewhere where people are competent to handle that. It's a very difficult situation, as you said, also in a preemie, because the kids I'm referring to are preemies. Like somebody put in a radial line, axillary line, or femoral line, and the whole limb is gone. I mean, I've got pictures where this becomes darker and you have to self-amputation. Last kid I remember in Acute had self-amputation. And so it's crucial. One of the messages I can give to the residents is you have to consult hematologists right away. And Jerudi gets very upset if he's not consulted. And this last kid was not consulted. Very sad. So, and again, the other thing I want to share is often our consultants put protein C, protein S, antithrombin in the differential diagnosis of seizures, the CNS. It is not possible, I mean, it doesn't present in the neonatal period. because they have low levels. It's very difficult. So the easiest and the cheapest, one of the things you heard from him, is difficult to do these blood levels. So you go, these are all genetically transmitted diseases. So you go into the levels in the mother and father and then decide. And levels of any anticoagulants, Judy will tell you, are absolutely unreliable for the first 4 months of life. And I wish he was here to
Yeah,
speak for himself.
thrombophilia I didn't mention, but what Pramanic is saying is, it's true. So if you have to check the level of protein C, protein S, you can check it from mom at mother's blood. The gene mutations can be checked in baby, and the 2 gene mutations, the common ones are factor V latent mutation and prothrombin gene mutation. Rest of like all these protein C, protein S, everything should be done in mom's blood. Baby, because again the levels are low, so it's going to be falsely decreased. It won't be true. But you can check for gene mutation, but that's the only thing you can do.
All right, well, again, thank you. We use catheters so frequently in the nursery because of the importance to keep these babies alive, and yet we've got to pay attention to the importance of the complications and how frequent they are, so we need to be aware. So it's a great presentation. Thank you.
Joe, that's a good point. In my French English, I get pissed off when I come as attending and I see a venous catheter because of the blood flow in the umbilical venous catheter. It's very common, number one. I've seen a number of babies with portal vein thrombosis. I was also looking around the room to see if my gastroenterologist is here, because they are the ones who are going to see the sequelae of portal hypertension, esophageal varices, and so on. So personally, I've always been a big advocate of removing the UVC maximum in 48, 72 hours and putting in a PICC line. Again, the type of catheters is very important, how thrombogenic they are. In the old days, one of my fellows did a study with me on, we were looking at these catheters under the transmission electron microscopy, and depending on the manufacturer, depending on the material, they have little holes where it's easy to get. Remember, I think you were involved in one of them with staph colonization, because unless you remove that catheter, he's going to get seeded in small amounts from there. So that's very, very important. And the site too, not related to this talk, because catheters can migrate. So very often we've seen, in fact, a couple of weeks ago, I saw a baby whose catheter had migrated to the heart. So you never ever want a catheter in the heart, because then you can get superior vena cava syndrome or SVT. So.
Yeah, talking about, we just had a baby last night actually, developed SVT. Pick was a little bit in the heart, and they had to use 3 courses of adenosine after ice. That last night. So.
Right. Along those lines, Nitin, it's very important to, when we pull the catheter, you must, some NNPs are reluctant, you must repeat the x-ray. Imagine a baby who's 600 grams, you think you moved it a centimeter or so, but the repeat x-ray shows, again, the position of your arm, how if it's an pick catheter from up here, if your arm is extended, it'll give you completely wrong position of the tip, so it's very crucial. And those are the kids that suddenly crash and die, because you can get a pericardial effusion or pleural effusion if your catheter is in the wrong place. My 2 cents.
But we have another class that needs to get in here, so we have to go here. Remember, again, we're going downstairs for our photographs, faculty, residents, and on down.